Okay, it's 9 o'clock. We have a good amount of people. Hello, everyone. Welcome to the University of Washington Division of Rheumatology Ground Rounds. A couple of reminders before we start the session. This session is currently being recorded and will be posted later on our website. There will be a Q&A session at the end, so please add your questions in the Q&A feature and not in the chat box so that it's easier to moderate. And now I'll let Dr. Sabo introduce our speaker for today.
Okay, we're so fortunate to have Dr. Jill Buyon here with us today. Dr. Buyon's a professor of medicine, the director of the Division of Rheumatology at NYU, and the director of the Lupus Center. In all of her remaining free time, she's led and contributed to innumerable publications which have advanced the care we provide to women during their reproductive years. Thank you for your work in the field. Thank you for being with us here
Great.
today.
Thank you for having me. So the title of today's talk is The Triple Threats of Lupus Pregnancy. That was what I was asked to more or less speak about, but most of you probably know that the original research and truly the heart of my research are considerations for anti-Ro exposure. So I will move quickly through the beginning so that I can really focus on what I really love doing. So these are disclosures, and while I'm drinking Coke, it's not that I drink Coke for coffee in the morning, it's actually lunchtime here, but you're probably about drinking your coffee. And here I think are the reasons that you want to stay awake during this talk. So these are three areas that I hope you'll feel comfortable about to some extent. You're called by your OB colleagues at 3 a.m., of course it's 3 a.m., to offer advice on a 23-year-old African-American female with a history of lupus nephritis. She's now 26 weeks pregnant. She's got a pounding headache, high blood pressure, and proteinuria. A patient seeks your advice on the use of anticoagulation for low-titer antiphospholipid antibody when she becomes pregnant. And an asymptomatic woman is just told that at 20 weeks, she's carrying a fetus with complete heart block. And she wonders, why in the world would someone tell her that she's been diagnosed with lupus? So this is sort of just a briefing. You are going to have access to these slides. You can obviously look these up on your own, but just to set the playing field that most of you are aware, we like to advise remission for 6 months. And you might say, well, what exactly is remission? Remission is really a patient personal thing. And clearly you could be still serologically active and be even in DORIS remission. So I think this is individual, but DORIS remission covers this, I think, extremely well. But you want to make sure your reasoning here is that you adjust medications. So the big no-nos are clearly cyclophosphamide. That's definitely a no-no, though at the very end of pregnancy, if someone is really in trouble, yet maybe a consideration. Methotrexate, absolute no-no. I'm sure when you give it, you're very careful about cautioning on birth control. Mycophenolate, same category. But what I think is interesting to discuss just for 1 second, and it will actually come up at the very end of this presentation for a different reason, is about the monoclonal antibodies. And belimumab and rituximab are being used more and more in lupus, particularly belimumab. And people ask all the time, should I stop my belimumab before conceiving? And how long? And what do I do about breastfeeding? So I just want to state for a little bit of interest, although this particular paper, I'm not sure where exactly that leaves us. As you will see, it's very early on, it's limited data, but Michelle Petrie did put together in 2023 data that we can utilize to help guide us to some extent for our patients. And she looked at the summary on birth defects and pregnancy loss after exposure to belimumab. And she had 3 sources. One was a belimumab pregnancy registry. One was actually its use in clinical trials where people got pregnant. And then there were post-marketing reports, again, of patients exposed. The bottom line is that you can see, and at first you might go, oh, look at all those miscarriages and stillbirths. The truth is that if you really look carefully at the data, number one, there were no consistent birth defects. And this is important. When you think about birth defects, it's the consistency of the birth defects that will scare you. And then if you look at estimates of loss in lupus patients, and obviously, because I'm going to get into if you're very sick or if you're not, that will change the data. But by and large, the signals were not really that concerning. And I think that is actually important. And it's very logical for those of you who work in the RA field, which I don't. You're all very aware of monoclonals being okay in the beginning of pregnancy. Now, you might wonder, Gee, why is that okay? And I can't see who's in the audience, but Jaylee Nelson knows this better than I do, if she happens to be out there somewhere, that transport across the placenta is really via a very specific Fc receptor called FcRn. Now, the interesting part of this, and don't ask about the ethics of this study or anything else because it's not important. In 1996, people were able to do things we don't exactly do now. And we can see that on the y-axis is IgG in the fetal circulation, and gestational weeks is on the x-axis. And I immediately bring your attention to, here we are in the first trimester. Oh, look at that. There actually is no IgG crossing. So remember, your monoclonals are IgG. So no surprise, there should be no effect here. Oh, look here. There still isn't very much. So that really is the biologic basis for which we don't really worry too much about monoclonal antibodies before 20 weeks. So memorize this slide because I'm going to reintroduce it at the very end in a different context. Okay, now let's look at our favorite drug during pregnancy. And again, these slides are available to you. You may already know this. I don't want this to seem too medical student oriented, but the fact of the matter is we do highly recommend that you maintain Plaquenil during all lupus pregnancies. And the data to make you feel better about this, I think, is really contained in this very seminal paper by Chambers in 2021. The long and the short of this slide is that when 3 groups were compared, hydroxychloroquine exposed in women who had rheumatic autoimmune type diseases, non-exposed, they were rheumatic type patients, or totally healthy non-exposed, there really was no significant difference in doses at around up to 400 milligrams per day, or even greater in spontaneous abortion, preterm delivery, or growth measure. So when I'm consulting, I stick in this Chambers paper and I do the best I can to reassure patients. So what we're going to discuss somewhat briefly are triple threats facing a lupus patient. And I think we'd all recognize their maternal component. And here we're curious and we're wondering about disease activity. We do worry, of course, about kidney disease, and we're ever plagued by preeclampsia. The placental component, very briefly, of course, it's pretty much APL driven. And then I'll speak at the end about my favorite topic, anti-Ro antibodies and neonatal lupus. So this is kind of a summary, if you will, a meta-analysis that took us from 2001 to 2016. I don't think the data are really changed. And this was really a very large meta-analysis. I think you can see the numbers here are pretty large. And what you really take home from this study, and we kind of corroborate this in a study I will discuss with you, but look at the preeclampsia risk, almost 9%. We see premature risk, and I was just a co-author on a paper that even further emphasizes maybe even higher. Small for gestational age, stillborn, death, NICU. So we see that lupus patients, and of course in this study, there really wasn't the consideration of active, non-active medications, but it does give you a landscape. While the data are very encouraging, and I'm going to show you really encouraging data, I still think we have to take some pause in telling a patient, hey, at least the very consistency of premature births and preeclampsia is there. And I would venture it's even despite being clinically inactive. So I draw upon a study that would horrify some of you youngsters, initiated literally in 2003 with Jane Salmon, who was the lead, and she called me in to help her out with the lupus aspect. And the question we were really asking were, hey, what are some predictors of poor pregnancy outcomes in people with APL only, lupus and APL, lupus only, and how does that compare to healthy? Right off the bat, I want to say, number one, this is still the largest prospective study done of its kind across multi-center and multi-ethnicity. And I would also say that these were lupus patients that you would have, by and large, considered to be stable and probably would have given them the green light to go ahead and get pregnant. Now, our primary adverse pregnancy outcomes are pretty standard. People use these all the time, and you'll see these currently used in many studies that you read about today. Fetal death, neonatal death, preterm birth, but here indicated by placental insufficiency, hypertension, or preeclampsia. So if you fell in the street and you wound up delivering at 32 weeks, that would not count. Pre-prom, which is premature rupture of the membranes earlier, but you don't have any reason in this particular study, did not count. However, in studies that I've done subsequent to that, even if I'm not sure why, but it isn't an accident or something weird, if somebody, delivers early for premature, whatever reason, I still am not sure that is not an adverse pregnancy outcome. And then very small for gestational age. This is actually quite small. So overall, how did it look in relatively stable patients? It turned out that adverse pregnancy outcomes occurred in 19% of these 385 patients. This is your ethnic background. Now, you could say, gee, Jill, that's not so great. We kind of said it was great because we said 80% of people doing well was certainly a lot better than what the literature had suggested. But at any rate, here are the data, and this is compared to the healthies are in white, and I might point out, these were super healthy people. These were individuals who had at least one successful pregnancy. And that makes a big difference when you look at general population norms, because all of a sudden your eye's going to go, what? They did better than the general, because there really are not good data on preterm birth in the general population, mixing everyone together. But suffice it to say, and the outcome 19%, fetal death around 4%, neonatal death 2%, preterm birth around 8% in this study, small for gestational age, actually 10%, and preeclampsia anytime fell, sorry, there's somebody's doing construction behind me just to make this more exciting, about 8.9% here, which is really consistent, very much so, with the literature. But really, what were the predictors of pregnancy outcome? So as I have a woman coming in to see me right after this lecture is over, this is what she is going to ask me, and this is what I'm going to tell her. So the predictor values that fell out of this study, and I will tell you, have been reproduced pretty much across the world now by Jane Salmon and other cohorts. Being non-Hispanic white in a lupus patient already does put you at some risk for doing worse than if you're white. Being on current antihypertensive use, regardless of the reason, actually confers a risk. A low platelet count confers a risk. The highest risk in this cohort, and again, I think this held up pretty well, is the presence of a lupus anticoagulant, and being a little active versus completely non-active also played a role. Now, interestingly, this is, of course, the physician global assessment. And you know the scale is 0 to 3. We all do this maybe a little bit differently, but this panned out, whereas the SLE actually did not pan out. And I make the point that I think we, as physicians, when we think about how sick someone is in front of us, in many ways, I do value that more than SLE days, which, as you know, you could have thrombocytopenia and have a SLE day of 1, and you could have, a little oral ulcer, a slight hair fall, and a complement below just 1 point and be 6. So I think this is meaningful, and I'm not so surprised about the SLE day. Okay, hold on. Okay, so as you move through pregnancy, do you accumulate any other predictors of pregnancy loss, of poor pregnancy outcome? Here, a patient who flares during pregnancy, be a little concerned about, but importantly, and this is hard to operationalize, but as you're following someone through pregnancy, I think it would be advisable to get complements at every visit, because you're looking for a rise in the complement because of an effect of estrogen on the liver. And you could make the argument that if you didn't see complement rise, you might be a little worried that you're taking out of the bank account. Now, obviously, I won't act on that, but I might see someone more often whose complement was not rising. Now, if we take those factors and reevaluate promise, actually gets kind of interesting. So in the yellow are patients who had no risk factors, and there were 129 of those patients. Now you see that the adverse pregnancy rate went down substantially. Same thing with the fetal and neonatal death, Same thing with preterm birth, same thing with small gestational age. So when you have none of these factors, you actually do extremely well. Now, what about flares during pregnancy? This was kind of interesting, and actually, as I might have predicted, the mild moderate flare rate pretty low, and even lower, the severe flare rate in patients who were pretty stable when they started. So I think we can conclude, and this may be slightly different than Michelle Petrie's data, but in in stable lupus patients, there really shouldn't be an expectation that just because they get pregnant, they're going to have a flare. And in fact, a study that I did with Michelle, like in another century, but also the largest prospective study to ever address the oral contraceptive safety, there were actually more mild flares in that study than there even were in these people in pregnancy. And we thought oral contraceptives should be considered safe. So what about predictors of flare during pregnancy? Well, the age seemed to make a difference. The screening C4 and the screening PGA, not very big surprises. But there were no predictors of postpartum flares. And I would point out, yes, there were really not severe postpartum flares, but there were more postpartum flares than there were during pregnancy. But none of these really raised much of an eyebrow. So I think the lessons learned in patients with no risk factors at baseline, the adverse rate is about 8%, but neonatal mortality continued to plague us, and that is of concern. In patients who are not white but have no other risk factors, the APO rate was around 11%. So that's kind of concerning a little bit, but I think we know that in Latinos, in Blacks, Asians, that there is a higher rate of pregnancy problems. In patients who are either LAC positive or are LAC negative but non-white and treated with a hypertensive, wow, the APO rate is 58% with a very high fetal neonatal mortality. So again, things are not, it's not all perfect, and flares overall were uncommon. Now, I think this is actually a point most of you spend your thinking cap on, and that is, what about renal disease? And I think a major question, at least my patients ask, is does pregnancy increase the risk of getting kidney involvement? A good question. In patients who had previous kidney disease, does pregnancy raise the likelihood of a kidney flare? And are patients, particularly those with past renal disease, who are clinically stable but serologically active, because those always sort of scare me, are they at increased risk of a kidney flare? So I went back to PROMISE, which I think was a pretty robust data set to ask that question. And it turns out overall, and there were, as you know, look at all these 385 patients, 17 renal flares de novo occurring in PROMISE. So flares meaning they had previously had renal disease or they developed it for the first time. So in the study, there were 118 patients who had previous kidney disease. And most of these had had a kidney biopsy. Only 7 flares in the second trimester and 6 in the third. And the way we define flares was really greater than 500 milligrams at UPCR. And that's, that was our definition. And no previous kidney disease. Look at this, 255 patients, 2 de novo in the second, 2 in the third. So I think we can pretty safely say pregnancy is not going to be a driver of new kidney disease. But also importantly, patient in complete renal remission had fewer renal flares than those in partial remission. And we define that by the level of proteinuria, though it may be that we realize proteinuria is not the end and be all. That's another lecture on urinary biomarkers I will not get into now. So what were the predictors? And it turned out in our case, a low C4 predicted renal issues, and of course, a history of kidney disease predicted it. But DNA had no bearing. Interestingly, neither did baseline proteinuria, baseline creatinine, or even BP or antibodies to DNA. That really, these are not predictors even in patients with past kidney disease. So how we deal with serologic activity remains a very important area of research, whether it's pregnancy or whether it's not pregnancy. Again, another lecture. So I want to just make sure everybody knows what preeclampsia is and how it's defined. It's hypertension, systolic blood pressure 140 or diastolic 90, 2 occasions 4 hours apart. They haven't really changed this definition, plus at least one of the following. Now, importantly, I'm emphasizing one. That means you could have hypertension and thrombocytopenia and might not have proteinuria, or you might have abnormal liver enzymes. You might have new renal insufficiency, you might have pulmonary edema, and God forbid, you had cerebral or visual disturbances. Obviously, we almost always talk about proteinuria, but the truth is, you could have one of these bad things and also have preeclampsia. Then there is this awful thing called the HELP syndrome, which is hemolysis, elevated liver enzymes, low platelets. This demands immediate delivery, no matter where you're at. But I will tell you, I have seen a few of our lupus patients have abnormal liver enzymes, and it turns out they actually have intrahepatic cholestasis of pregnancy. So I've been getting used to asking people about itching and getting bile salts, bile acids. I think it's kind of interesting and something I've seen in a few of our lupus patients. Now, this is the part where you're woken up at 3 o'clock in the morning. Of course, it's always 3 o'clock in the morning. And how are you going to differentiate lupus nephritis from preeclampsia? Well, the first thing is you may not be able to. Unfortunately, you might not be able to. In fact, many times you really can't. And there have been many publications on this very theme with tables presented that look different than this. This is my view. It is not necessarily the view held by everybody, but I'm just going to present how I think about this at 3 o'clock in the morning. Well, number one, we know that with lupus nephritis, you don't have to have hypertension. So we're really going to say there won't be any discussion here if there isn't hypertension. So if it's proteinuria alone and it's not hypertensive, there isn't a blood pressure requirement, you better be thinking lupus nephritis. Okay, but now we're going to deal with the other concept. Generally speaking, preeclampsia is a 3rd trimester disease. And if you see these things earlier, you've got to be, number one, extremely worried and be thinking it could be preeclampsia, but I bet there's underlying kidney disease here also. The level of proteinuria is not going to help you. You can see massive proteinuria in preeclampsia, and I have. Edema is not going to help you. Many patients become edematous and fluid retention, etc. Obstetricians get less worried about that than I do. Now, here is the craziest thing I want to tell you, and I did not realize that, but in current obstetric standard of care, and I'm not kidding you, so watch out, getting a urine analysis at each of their visits is no longer required because they say they can't interpret it. I never heard of anything so crazy, but our MFM let me know this when I noted that there were no urines done on a patient of mine who said, oh, I never give my urine. I would be very concerned and let your MFM know that's bullshit for our rheumatic patients and that they really need to do this at every visit. So an active sediment, which you rarely are going to tell unless you're going to look under the microscope yourself, but you shouldn't see an active sediment in preeclampsia. But we all know with membranous nephritis, you may not see an active sediment. But if you were to see red cell casts, you're done. This is at least active nephritis. Uric acid for me has been helpful, although MFM often dismiss me, but it's elevated very often in preeclampsia. And I'm not going to go through the soluble FLT1 and that sort of these enzymes and proteins that help us, like VEGFR. I'm going to not discuss that now, but these things are being maybe commercialized, and some of the soluble FLT1 stuff may wind up being interesting and more pertinent to preeclampsia than lupus nephritis. But the jury is still not completely settled. Megan Klaus presented this at the ACR meeting and very disappointingly couldn't use those to differentiate between nephritis and preeclampsia. ANA, generally absent in preeclampsia, but keep in mind, this could be the first presentation of lupus. So if you see someone or are called about someone with proteinuria, you should get an ANA. The ANA being positive, it's not going to clinch your diagnosis, of course, but you might want to follow them postpartum. DNA, obviously, you don't always see it. When you do, you should probably worry. And really, really low complements are going to be much more likely to be active nephritis, though semi-low could be seen in preeclampsia. So I think from a practical point of view, I would consider new onset lupus with kidney involvement whenever you're called about a patient for preeclampsia in the second trimester, because that's scary. Shouldn't be then. And I think your job is you should say, okay, fine, I'll order appropriate serologies. Now, if established lupus patient has a previous history of nephritis, worsening proteinuria, but nothing going on in the sediment, everything else is okay, and no hypertension, yes, it could be lupus, but I would be cautious about overtreating with steroids and not just watching. A rise in blood pressure and proteinuria and no urinary sediment, then I think you really do want to consider preeclampsia. But again, these conditions can coexist. So I think the important point here is that for all lupus pregnancies, you need to consider preeclampsia prophylaxis. So we recommend 81 milligrams of aspirin. Some people recommend higher. If there's prior preeclampsia, I'd start in the first trimester. Now, it turns out, this is kind of interesting, where you always had to remember, oh, make sure we tell the patient to stop a week before delivery. The ACOG has said, nope, you don't need to do that. There's no problem. There's no contraindication to neuraxial blockade. Don't even think about it. Just keep somebody on it throughout the pregnancy. And remember, this is not for APL consideration. This is for preeclampsia. It's independent of anything to do with APL. Okay. Now, I'm bringing this up because I think this is sort of interesting, and you may be seeing this with your OB colleagues, and that is you may have a patient who's been fine during pregnancy, and the patient calls you and says, hello, I was just told I have to take Lovenox for the next 6 weeks. And you're going, why? Huh? You were fine. But I've had this occasion happen, and on the other hand, there have been several reports there lately about cardiovascular risk in our lupus patients. It turns out that there is a scoring system for DVT prophylaxis put forward by the Royal College of Obstetrics and Gynecology. And this is sort of interesting. If you have 3 points scored on this, it is considered prudent to give actually Lovenox for 6 weeks. Now, what gives you 3 points is interesting. Active lupus is actually on their list. The problem is you might define active lupus, but maybe your FMM or OB colleagues are not, and they're putting all lupus patients. So be careful about that. On the other hand, you can accumulate 3 points if you happen to have APL only, though never had a problem. We'll get to that. If it happened that your patient had a C-section and it happened that your patient delivered at 36 weeks, actually by this scoring, that would constitute a reason to give Lovenox. So this is just something that I think would be worth you thinking about. Okay, I looked this up for all of you because I've been also plagued by people and what is really antiphospholipid syndrome from the perspective of obstetric. So I highlight this in this particular lecture. This is not about you had a previous clot, this and that. This is strictly reviewing, because I think it's interesting to look at it again. What are the obstetric clinical criteria for APL? You figure now I've moved into the APL category here. So I want to tell you that, interestingly, to be considered antiphospholipid syndrome, you need 3 clinical and 3 lab. Just skipping to the lab, I think this is important because actually the consult I'm seeing right after this lecture, this is actually pertinent. And why? So if you have a lac only once, very little points here. But if you have a persistent lac, like 2 times over 12 weeks, you automatically would qualify for the laboratory criteria for the APL syndrome. Now, interestingly, and this is where I get a lot of consults, moderate or high IgM, ACL, or beta 2, but not IgG, only 1 point. And I think that's kind of interesting. So if somebody comes to you with moderate, and moderate, I looked up for you guys, over 40, let's just say someone has, 41, and that's all they have, and they got both. That actually is not enough to say, oh, you've got the syndrome. So just keep that in mind. Now we look at the clinical side, and this is also interesting. So greater than or equal to 3 pre-fetal still only gives you 1 point. That's not enough. So if you had 3 pre-fetal, that wouldn't be enough. That's kind of, interesting, right? And 1 early death wouldn't be enough either. But if you had a fetal death, this is very curious to me, later, but in the absence of preeclampsia or severe features of placental insufficiency, you also only get 1 point. So really, to qualify from purely obstetrical perspective, bad stuff has to have happened. And you can't just have IgM, ACL, or beta 2. So I just wanted to review that. Maybe you already knew it better than I did, but I do think it's kind of interesting. Back to PROMISE, let me just say that in our study, we unequivocally identified that the lac was the driver. So even if you had high positive beta 2 or ACL, but in our case, we were in the moderate range, and then we called that high positive. So this was not done as greater than 80. Suffice to say, these are the drivers. Whether you have lupus or not, that's the driver of poor pregnancy outcome. And I just cut to the chase and tell you that the PROMISE study was actually divided into 2 parts. So we did the original data was Lokshin, and then we followed up in the second part, and the same thing, LAC was the driver. Now, what about the American College of Rheumatology and EULAR guidelines for just APL positive test? Now, if you never had a history of a clotting event, never, low dose aspirin, we already discussed that, but that really was for preventing preeclampsia. But you know how many of your OB colleagues want to throw Lovenox at the patient because they have a positive, and any kind of APL antibody? And the answer is, from your perspective, your guidelines of your societies. Now, you might not believe in all that society guideline stuff, but you could stand on those laurels and say, no, we would not recommend it. Now, for obstetric APS, okay, now, and I already gave you the definition there, so now you have more familiarity with it. Now we would agree, of course, we would go with low dose aspirin. Obviously, we would consider hydroxychloroquine, even if you weren't lupus necessarily, but we wouldn't go with therapeutic dose, and we certainly wouldn't go with prednisone. If you've got thrombotic, then you go much further along for full anticoagulation. I want to introduce what I think is probably one of the most exciting studies that you're going to hear about. I'm very jealous of this. And I'm excited for Jane and her group and Ware Branch. This is the IMPACT study. I think you're going to be hearing about it soon. It's been submitted for publication. I don't know exactly where it's at. But this is the IMPACT study. My involvement in the study is that I came up with the name. That's it. I did enroll 1 patient in the study who did really well. Anyway, the goal here was to evaluate the efficacy of TNF blockade in pregnant women with antiphospholipid syndrome, and they had to have a lupus anticoagulant. They received certolizumab, and that has no FC portion, so that's not even going to cross the placenta. And it was given in addition to aspirin and heparin, and the outcomes were bad stuff. This were their primary outcomes: fetal death, severe preeclampsia, and requiring early delivery. Well, what did they find? Results so far: 51 subjects screened and enrolled, 43 completed pregnancies, adverse outcome 16%, 17%, intention to treat 18, 19% observed primary outcomes versus 44% expected. Now, of course, this was an open label study. That's okay. We know the problems, but versus the historical control, this is very, very, very exciting. And I think you should keep your eye on it and think about your patients who might qualify and think about certolizumab. I'm actually very excited for her and for the patients. So just to wrap up this little part before I get to my favorite part, I'm watching the time. Basically, I would get compliments at every trimester. I do DNA at every trimester. I don't do Rowan law. That's steady state. We don't do antiphospholipid. That was shown in the PROMISE study. I definitely get a spot urine for UPCR each trimester. I think it's really important, and I'm shocked our obstetric colleagues don't do that. And I also get a vitamin D level, and I've always done that. And Michelle Petrie also recently published that's a good idea also. Okay, and don't forget your biophysical profiles. Even if your lupus patient is doing well, she's still at higher risk for preeclamptic stuff and IUGR. So I now want to turn to the fetal component, and this is a picture of Mo Reichland, and I just want to say he was the father of anti-Ro antibodies, a former mentor of mine, and we had a memorial service for him a couple of months ago. This is a problem that is dependent on Ro, and I'm going to skip or not say too much about antibodies, but it seems to be a problem that is independent of the mother's health. So what is this thing, this neonatal lupus? It's not lupus, and the mother doesn't have to have lupus. It's a model of what we consider passively acquired autoimmunity, where the mother might have lupus, Sjogren's, or be absolutely asymptomatic. She had no idea. But it seems the requirement are to have some component of the anti-Ro and La system, most commonly 60 and 52 Ro. These antibodies, like all IgG antibodies and subclasses, cross the human placenta via FcRn, and I will end the lecture discussing that. And in fact, I began the lecture discussing that with regard to biologics. What are the manifestations? Well, congenital heart block is the one that we most worry about. This is pretty permanent. Neonatal rash is transient, and this can happen at birth, but more commonly actually at 6 weeks. And be careful about the sun exposure. Back to heart block. 2% risk of no previously affected child. That was the general word. That was, basically the percent you would write on your boards. I'll have a few more things to say about that in a moment. Recurrence rates as high as 18% with no therapy. Third-degree block is permanent, unfortunately. Second, we think could be reversible. It's a disease that carries a significant mortality. And if you've got a cardiomyopathy, even worse. And almost all the kids as they grow older will need a pacemaker. Now, I'm going to actually kind of give the end at the beginning that pretty much I'm going to talk a little bit about mothers with high titer antibodies, and I'm going to talk a little bit about hydroxychloroquine. We've discussed vitamin D, but steroids are not recommended. Treatment of first-degree block, if you're following the patient, I think we need to better define what first-degree block is, and I would tell you that 150, which is what people mostly use, may not really mean anything, and most studies show that that can spontaneously reverse. A few cases have gone on to second and third. I'm going to discuss a little bit about second-degree block, but the treatment for many people is dexamethasone and IVIG, and to date, third degree is not reversible, and whether you should treat isolated third degree, another very controversial point. Summarized by actually papers that you might find interesting if this topic is exciting to you. Natalie Costa-Doat and MFM have come out with guidelines that may shock you that say, stop monitoring. No reason. We can't do anything. Don't bother monitoring. Well, this set off us, even though she's a rheumatologist, and the pediatric cardiologists. It put them in a complete apoplectic frenzy. And now there's a very big controversy about what you really do between here and here. If you have first degree on EKG at birth, and I would submit that these mothers should have their kids get an EKG at birth, you might want to have the kid followed. If it's normal sinus rhythm, you're done. Okay, so let's dive in a little more. We've said the third degree is not fixable so far. Therefore, prevention is the way to go. I can highlight this one paper, which now it's scary to think it's 5 years old when I thought it was yesterday, but Peter, Ismail, and I, based on some basic science I'm not going to tell you about now, we did an open label study to address whether hydroxychloroquine at 400 milligrams starting from 10 weeks on would be preventative of recurrent block. And we took the historical control of 18%. It was a 2-stage study, not important. Bottom line is we were able to show that the percent of recurrent heart block was actually divided in half. So interesting data. And right now we're very prescriptive of this. and putting women, whether they have whatever their maternal disease is, if they have had a prior child with heart block, to prescribe 400 milligrams of hydroxychloroquine per day, starting as soon as in pregnancy as they can, but certainly before 10 weeks. Now, we've continued to look, at least I have, and we maintain our registry, we maintain the information, and basically we're not quite as good as we were before, but still showing, as the data become larger and larger, that in fact we are reducing the recurrence rate of block. So I would suggest, and I wrote this boldly and up to date, that if a woman has no other contraindication, that she should, regardless of her health status, be started on hydroxychloroquine if she's had a prior child with heart block. The big question, which you probably all put in the chat, so I'll just say, primary prevention, I'm sort of like, why not? But it's not like the data are as strong. I basically do decision management with the patient. I describe these and I say, here's what you might want to consider. Now, I have to say this is the funniest thing, and I've never bragged. I just thought it was so adorable. Someone sent me this slide from this year's Final Jeopardy at the ACR Knowledge Bowl. This medication decreases the risk of neonatal congenital heart block among pregnant women with anti-Ro antibodies. Now, what was the answer? The answer was, what is hydroxychloroquine? But I would argue the question should have said, decreases the risk of recurrent. But it looks like this has become so popular that it's the first time that anything I've ever done has made it to the Final Jeopardy. So now, what about clinical priorities in addressing the approach to anti-Ro exposed pregnancies? This is very interesting. We want to identify the highest risk mother by assessing antibody titers. Aha! If your titer is really low and heart block we're saying is occurring right here, so I'm going to address that in a moment. We want to optimize a surveillance method which might really pick up a potentially reversible conduction defect. And we'd like to see, if we could do that, what would be the most potent anti-inflammatory therapy if given quickly? Could we prevent permanent block? So this is actually the study called Stop Block. It is basically run by Bettina Cuneo and myself with a great coordinator, unbelievable. And I will tell you all that although the study has only two more years to go, Seattle has been, we're trying to finish the fine print, but you guys will be a site hopefully in the next month or so. So if you have a woman with anti-Ro antibodies who's pregnant, please let me know, because actually you are going to be a site. Inclusion criteria, less than 20 weeks gestation, Ro antibodies positive at any commercial lab. And I don't know how you guys do your Ro antibodies. We could discuss that offline or whatever. And you have to live within 6 hours of an enrolling site. And why? Because we got to get you to an echo if your FHRM is abnormal. There are 3 steps to this. First step, do you have high levels of anti-60 or 52? And we actually do this in our lab, and I'll give you an example. If you do, because we're fairly certain that if you have low titer Ro antibodies, you're actually not at risk at all. We then prescribe FHRM, that's fetal heart rate monitoring. That is the little monitor. Presently, women send the text 3 times a day to our coordinating center, which is Bettina, cardiologist, and Mala Masson, who can listen to these texts better than most cardiologists can. And if they're abnormal, then immediately the patient is sent in for an echo. That's why she has to live within 6 hours. If it's second-degree block, she gets treated with IV and IG and DEX. So how are we doing? As of December 20th, I'm sorry I didn't update this in the last 2 weeks. I think we're at 715 now, maybe. But we have enrolled over 700 patients. And interestingly, based on our prediction, defining high risk, or rather high titer, as greater than 1,000 EU, and I'll just show you this in a minute, basically 245 women, or about a third, probably are not at risk for block at all. So of all the women out there with Ro antibodies, probably 1/3 probably don't need monitoring. Now, could we show this in this study? And these are all the places across the country. So you're here and we need you. Okay, so this is from a publication about a year ago, and I purposefully, I'm holding back on telling you anything beyond this. Our statisticians don't want us to talk about the last year, so I'm presenting the work that's admittedly published. 413 women as of last year were tested. As we thought, a third would be low titer. Not one single case of heart block came in the low titer group. Of the high titer group, we had 10 cases of block, and this is where we're at, 10 cases of heart block, and this is 2 had first degree block that was resolved, and we really are not even so sure when we went back and looked at the PR intervals whether they were first degree. So right now, we really don't think we saw any first degree. So I just want to comment, I should have updated that. But the bottom line is there were 10 cases out of 261 high titer with advanced block. This is what the row ELISA looks like. The point here is to show you all of these women were commercially positive, and there are about 15 different laboratories that we actually have, and we're thinking about publishing the values in our research lab versus the commercial value. But here's the point. All of those that are in white basically are below the 1,000 mark that we came up with by actually evaluating like 50 heart block mothers, and there were none that were below these levels. So already you can see these are all the patients that commercially were positive, but really wouldn't have fallen into any risk category for us. Then there were people who had only high 52 or only high row. And high, of course, is defined right here. Now, here's the interesting fact, okay? The block cases are all in these like bluish color. So what you can immediately see is, look at all these people who had sky high, look at these values. Nothing happened. So once you pass this threshold, what the heck other factors are contributing to the risk? And we're trying to work on that. But here are some numbers for counseling. That is to say that if your titers are low, and the best I can tell you is I don't know what you're doing in Seattle. I will once you're a site. But if you were doing bioplex, let's just say less than 8, probably low risk, greater than 8, high risk. But greater than 8 could be 9, or it could be 100,000. So we've seen a lot of greater than 8s that actually fall into low risk. But if you're less than 8, probably safe that you're not going to get a kid with heart block. So if you were in the high risk group, 3.8%. So we went from 2% risk to almost 4% risk with high titer. However, there are caveats to this that I can't disclose at the moment. So I'm just showing you what's published and out there for the moment. Previous child with heart block, almost 10%. Many of these patients, of course, were on hydroxychloroquine. Now, if you were sky high 60 and you had a previous kid with block, that the numbers are so painfully small that it's really hard to say anything here, but that was a higher risk category, the highest of all. Now, Yagi published a paper like a month before we did, where he was showing values like this in people who had high titer. There's no way that that's true, at least in our hands. It's higher, but it's not like 1 out of 4 with high titer are going to have a kid with heart block. That's just not true. I'll also point out, and this is really intriguing from a research point of view. What's intriguing is these women don't change their titers. So again, you meet a threshold, but something else is going on. What could that be? And now, just getting back to the point of our study, 7 cases were second degree block and 3 cases were third. These were all picked up by FHRM. In these cases, there was a delay in the women getting back to us or misinterpretation, long story, but FHRM unequivocally can pick up early block. How these people did, I'm not really able to discuss that with you yet, but there definitely were reversals in this group. So what can we conclude so far? High-risk antibodies confer an increase for block. Antibody titers remain stable over time. Don't explain the discordant. FHRM can detect second-degree block within a 12-hour window. I didn't emphasize that, but it's shocking. Less than there are almost no false positives, which is why FHRM is so exciting. And surveillance echo didn't detect any advanced block when the interval FHRM was normal. So I think we're going to see a shift in our recommendations about how many echoes are really needed. Now, I'd like to end up with some kind of, I don't know, I sort of like this idea, but anyway, ever stop to think that the timing of block, which is between very clear vulnerable period, between about 17, 18 weeks and 24. Now, I just told you that not too much antibody goes across the placenta at that time. At least that's what we were taught. And you might ask yourself, wait a minute, even though we know there's a strong association clinically, how do we know that Rho is really transported so early in human gestation? And so I can't believe I didn't ask myself this question 20 years ago, but suffice it to say, in the last year, 3 women have unfortunately had fetal demise. And I was able to ask each of these women if they would contribute their fetal bodily fluids to our laboratory and compare their levels with the mother's level. And what did we find? So this is taking you back to that figure that I showed. This is the 1,000 mark that I was pointing out. And this is kind of interesting. If we look at 52 and 60, and we look, these are the mother's levels, happen to be bad luck for the mothers, good luck for our science. They were very high titer. Each of these mothers had high titer for both 52 and 60. Their cord blood in one, you can see, wow, actually came to, a level over 1,000. Pleural fluid, same thing. Cord, pleural fluid, pericardial fluid. This fluid could not have come from the mother, not in a million years. And we also did IgM levels, and the mother had a little IgM, kids had nothing. So I think there is no question that Rho antibodies are there when they're supposed to be there. And the ratios look like what they would expect at that time of gestation. So these antibodies get there, and it kind of explains why high titer probably is important. So I want to end with a topic that has basically intrigued me and obsessed me in the last year. I haven't stopped thinking about this, and that is, but putting the fancy science aside and the pathogenesis and fetal microchimerism, many, many interesting ideas here, which could be another lecture. We would really like to think no antibody, no disease. So what comes along but antibodies to the FcRn? Now, these antibodies, so FcRn, which I was describing, basically picks up IgG at an acid pH, the FcRn binds the antibody, protects it from the endosome, it moves back out, goes into the fetal circulation, releases it at a neutral pH. Everybody's happy. It keeps IgG in the mom, and it gives the kid IgG. If you block this receptor, these antibodies go into the lysosome. They don't get into the fetus. How exciting would that be? Even though you might lower a lot of IgG. Well, it turns out that actually IVIG is a proxy in a way, because it does flood up the FcRn, but it's 100 times less potent. And actually, there was a weird situation in our registry. This woman got 2 grams per kilogram, I swear, like weekly. She had 2 kids who died of heart block. We were able to lower her antibodies in her circulation, but I don't know how much of an effect it had on the baby circulation. But at any rate, she had a healthy kid. That's an interesting precedent. But we all have seen recently, I think, one of the most exciting papers I've ever read, and that was in the NEJM, Ken Moisey, who showed that mothers who had hemolytic disease of their newborns, given nipocalimab, that rate of poor outcomes dropped dramatically in these patients. It was 13 kids, and 12 out of 13 were born alive. This is really, really exciting data. So I just want you to think about that. I do think that this is a time where we might be able to actually completely prevent this disease. It would be amazing. Who knows? We shall see. So conclusions and clinical pearls. Stable lupus patients rarely flare. Past renal disease in complete remission carries a good prognosis. De novo renal disease is rare. Identifiable risk factors for poor outcome, I've stated, and I think it does hold up. Hydroxychloroquine and low-dose aspirin are highly recommended. Patients presenting with lupus during pregnancy are a totally other kettle of fish, and they may be much sicker and are different than what I've described. And the good news is, I think, low titer anti-Ro antibodies, you probably are not at risk for heart block. That's really it. I've got a whole team that I like to thank, and these are our heart block, and we couldn't run a lab without a lot of Diet Coke. So thank you all for listening. That's it.
Thank you. We have some questions. First of all, on the last topic you talked about, did you or anybody look at whether activity of if the women also had lupus and not just SSA antibody
Yeah,
positivity?
so without
Activity of
question, we
disease.
did. And
Yeah.
that was actually on a slide I passed way too quickly. And the answer was no, they didn't have active lupus. And it was split amongst most of the women, but the kids with heart block are actually not lupus mothers. But it is what it is. And we do not think that maternal health adds a risk. We don't.
Okay.
At the present time, anyway.
Okay, a couple other questions. Thanks for sharing your research. What is the pathophysiologic process linking SSA antibody to congenital heart block, i.e., are anti-SSA antibodies pathogenic or involved in pathophysiologic process?
So I will answer that briefly, although that could be a whole lecture. So I actually took out a slide that would just give a summary. There are prevailing theories as to why these antibodies might result in heart block. Some people think that these antibodies cross-react with the surface antigen on a cardiocyte, like a channel receptor. And there may actually be some data coming out, not from our lab, but from Canada, supporting that. I can only say that in our hands, when we add antibodies to living cardiocytes, we really don't see any binding. But, could be. So one theory is some cross-reactivity that's specific to a cardiac surface antigen. The second theory, which is our kind of theory, is that during human embryogenesis, Rho and La move to the cell surface and there become accessible to the antibodies. So when a cardiocyte undergoes apoptosis, which is part of normal physiologic development, antibodies bind, and the antibodies bring into the situation. They keep apoptotic cells from being normally taken up, and that is a problem because actually cardiocytes eat each other for normal physiologic remodeling. At any rate, if you have an apoptotic cell that's decorated with antibody, then this could be taken up by a macrophage through an Fc receptor, and the single-stranded RNA, which comes as part of the complex, could bind to toll-like receptors, and then downstream signaling, the macrophage puts out pro-fibrosing cytokines and pro-inflammatory, and I can tell you interferon is unequivocally one of them, and that turns the fibroblast to a myofibroblast, and thence you get scarring. So our theory really involves apoptosis, binding to the cardiocyte, ssRNA, the HYRNA, binding to toll-like receptors, and hence why we think Plaquenil makes a difference, cytokines released by macrophages that turn on the fibroblasts. That's our theory.
Okay. Next question. Does the probability of high titer SSA vary by diagnosis? Oh, I think we
No. So that's but that is the $1 million question. And the answer is unequivocally no. You could be walking around with 100,000 anti-Ro 52 and 60, and you never knew it. It's shocking.
The next question is about the heart block study and whether it's ongoing at UW. I'm not sure if you said you were hoping for that to happen or it is, and if so.
When you say UW, what is UW? Oh, UW.
Oh, sorry, University of Washington.
Yes, so there's under IRB review. We have a single IRB, and right now this is the last site we're trying to enroll. Yes, so no right now. Hopefully, yes in the next month.
Okay, and we'd love to know who we can send patients to.
And I will definitely let you know. Absolutely.
Okay. Have you looked at HIF1A as a possible contributor to increasing placental permeability to antibody?
So I have no idea who's out there asking the HIF1 alpha story. Actually, we published on HIF1 alpha maybe like 15 years ago. I shall go back and read the papers, but yes, we thought that hypoxia did play a role. We did a really weird experiment. To whoever's out there asking this question, and maybe we can talk offline, we actually took fetal cardiac fibroblasts, and we put them under hypoxic conditions. And we added the macrophage supernatants, and there was a difference, actually. So when you subjected these cells to hypoxia worse things happened when the ssRNA bound the toll-like receptors. And this is a paper, I can certainly find it and send it, but it was all about HIF-1 alpha and hypoxia. Very interesting person who asked that question.
Okay. Do you think that measuring row 52 versus row 60 is important?
No. So I said that a little too quickly. I think there's a lot of literature that 52 is the main player, and in fact, this P200 epitope. But the truth is, I think they're 60 and 52 are both important, and I can't currently separate it out. In the patients, the 10 of these prospective 700 that had the case, all of these mothers actually had high titer to both 52 and 60.
And then law is just set on the side.
Well, I sort of loved law in the beginning. It was my favorite. And I've sort of shifted over to row. I'm not sure how much more law adds. And we set up a really robust assay for 52 and 60. And that's kind of where we're at right now.
Okay.
And by the way, you really don't have law without row. That's another interesting discussion. So if you really want to have your bang, if you're row negative, the chances that you have law that's meaningful at all is probably almost zero. Although I was first to publish that existence, I don't really believe much in it anymore.
Okay, a few more questions, which maybe we can answer in a few minutes. Is the cardiomyopathy just related to the congenital heart block, or is there another mechanism?
Well, I say yes and no because you can see extranodal, meaning endocardial fibroelastosis and valvular problems can actually occur without conduction damage. So this is curious, but clearly these antibodies or something also can damage the myocardiocytes, not just lay down scar in the AV nodal area. So I think yes to that one.
Okay. Is there something different about the antibodies themselves when heart block occurs versus not? Example,
No.
different subclasses or FC receptor binding differences?
I don't know the answer to that. I do know one thing because of this FCRN, and let me just say that I'm really into this. Wrote a grant that probably will never get funded on it. But the fact is that I was thinking about subclasses, and I don't know if it makes any difference, but we did look at subclasses and it did not make any difference. So IgG1 dominates row 60, but it didn't differentiate mothers who had block versus who didn't. But what we're doing now is we have like matching mothers for everything you guys can think of, titer, race, disease, whatever, and saying, okay, let's now submit this to agnostic proteomics or antibody arrays and see if we can find a difference. And we're working on that right now.
Okay. These questions are treatment-based. They might be longer conversations, but in summary, the few questions we have on that are related to postpartum care in lupus, pearls, pitfalls, and steroid treatment during pregnancy, recommendations, and treatment before, conception planning, regardless of disease activity, to sort of tee them up appropriately for pregnancy.
Okay, so I think regardless of any activity, hydroxychloroquine should be given to all pregnant, prospective, blah, blah, probably all lupus patients anyway, but maintained during pregnancy. I think that's very clear. For heart block prevention, also good, whether if you're asymptomatic and you've never been pregnant before and you happen to have row antibodies for God knows what reason they tested it, I think little less certain, but I think the safety of the drug and the expense of the drug, probably why not? Let's see. There are a million questions here. So if you're sick during, lupus pregnancy, steroids are probably your first line of consideration. But remember, you can use tacrolimus, you can use azathioprine. So those are drugs that I definitely turn to when someone is sick during pregnancy. You can't do a kidney biopsy after about 15 weeks. So if you're really worried all of a sudden about proteinuria, get that biopsy done before you hit the mid to the late second trimester. I don't know what else they want. Sorry.
No, that was great. We bombarded you with questions. I think that's all for now.
Okay, so exciting. No one's ever asked me this many questions. I'm very proud of all of you. And I'm about to